Welcome everybody to the November webinar for our Penn Artificial Intelligence and Technologies for Healthy Aging Collaboratory, also known as Penn AI Tech, here at the University of Pennsylvania. Our center is funded by the National Institute on Aging. Our webinar series takes place once a month, and this session is being recorded. So today we're very happy and honored to have Dr. Max Topaz joining us as our speaker. Dr. Topaz is the Elizabeth Standish Gill Associate Professor at Columbia University School of Nursing, and he's also affiliated with the Columbia University Data Science Institute and the Center for Home Care Policy and Research at the VNS Health. His research focuses on data science, and he finds innovative ways to use the most recent technological breakthroughs like text or data mining, to improve human health. He's one of the pioneers in applying natural language processing to data generated by nurses. He earned his PhD degree as a Fulbright Fellow at the University of Pennsylvania, and his master's and bachelor's degrees from the University of Haifa in Israel. He completed a postdoctoral fellowship at the Harvard Medical School and Brigham Women's Hospital. So we are very happy to have him here and hear his presentation. You can post questions in the Q&A box. So at the end of his talk, we'll have some time for questions and answers. So with that, thank you, Max.
All right. Thank you, George. And thank you for inviting me to present to Penn AI Tech. You're doing a wonderful job with this project. Looking forward to see how things develop. So today I'm going to talk about applying speech recognition and natural language processing to improve patient outcomes in home healthcare. So in terms of the take-home message for today, artificial intelligence can help to automatically extract important insights from home health data to improve patient outcomes. And I'm going to reinforce that throughout the presentation. So in terms of the talk outline, I'll provide a brief personal bio to tell you, how I ended up doing what I do. And then we'll talk about two specific types of technologies that we use for artificial intelligence in home care, specifically natural language processing and speech recognition. I'll give you specific examples of those technologies, how are they being applied. And then we will summarize. So this is my birthplace. I was born in Russia, Siberia. My hometown looked something like that. So small industrial hometown in the Ural Mountains. Now, this is my first computer. So it was a hacked version, USSR hacked version of an American computer or UK-based computer. And I had to tinker with the tape, upload the software to this box, computer thing, and then connect this to the TV to be able to see, kind of the outputs. That's how my passion for informatics started, tinkering with all of this to be able to play a Soviet version of the Mario game. So that's how I kind of ended up being very interested in informatics. I then immigrated to Israel, where I was a combat medic in the Israeli army. And I actually was implementing some of the first electronic health records there. So that's that's kind of that was my exposure to both worlds of medical things and informatics things. So this is the University of Haifa, where I got my master's and bachelor's degrees in nursing. I worked at the Rambam Hospital in Haifa for a few years. That's my clinical experiences from there. Now, then I was fortunate to become a Fulbright Fellow, study with Katie Bowles, Mary Naylor, and John Holmes. That's at the University of Pennsylvania, where I really started focusing on informatics, specifically clinical decision support. I then moved on to the Harvard Medical School, where I learned a lot about natural language processing and started developing some of those tools. I then came back to Israel for a few years. I was the head of the health informatics lab at the University of Haifa. And then about 5 years ago, I started Columbia. So I'm at the School of Nursing and the Data Science Institute. And I work with an organization formerly called Visiting Nurse Service of New York, VNS Health now. It is a very large, the largest non-for-profit home care organization in the United States, providing care to about 40,000 individuals on the daily census. So huge organization, very fortunate to work with this. All right, this is my motto. So data for good. This is I take this from the Data Science Institute at Columbia. I add home health data for good. So that's my personal motto in research. That's what we're trying to do. So a couple of definitions I wanted to provide. So what's AI? Basically, so AI in healthcare is an overarching term used to describe the use of machine learning algorithms and software. And basically, kind of the major goal of AI is to build systems, computerized systems usually, that would resemble human thinking and be able to make some decisions, different degrees of decisions, kind of how autonomous those systems are. There are different degrees of that. And, that's the picture is an example of a recent AI thing. People probably heard about DALL-E, so DALL-E. DALL-E is a large model that was trained to generate images. So I prompted this model with a prompt nurse AI. That's what I got. So this is AI generated image, pretty cool. And you can get prompts like that or images like that in, dozens and tons. So, this is kind of an example of AI technology recently developed. What is home healthcare? So, because my work focuses a lot in home care, and for this presentation, we'll define that. So there are about 6 million patients that are admitted to home healthcare agencies across the United States every year. This number is higher, but this is under traditional Medicare paid for programs, and there are a variety of other programs that are going on right now. So this number is significantly higher actually, but that's kind of the official number. Then we have about 11,000 home care agencies across the United States. So lots of home care agencies. What is being done in home care basically is that the care that's being provided usually by a registered nurse, physical therapy, occupational therapy, and some social workers is skilled nursing care basically at home, physical therapy and exercise, pain management and treatment, and other things. Usually those interventions happen over a period of about 30 days, and this is called the home care episode. So, nurses and other clinicians are coming to visit patients. Again, another image that I generated for home care nursing. I don't know, all the nurses here in this image have hospital clothes or gowns or something like that, which is not the case in home care. So, but that's what artificial intelligence knows about home care. If I ask it and ask it to draw home care nurses, basically. All right. So there is a variety of healthcare data and data that we get in home care. With that, about 80% of the data that we get, healthcare data that we get, is in narrative, some type of a narrative or unstructured format. So those include some of the examples of those kinds of data include nursing and physical physician or other clinician clinical notes. So admission, assessment, follow-up, comments, discharge, radiology. You have gazillion number of notes in hospitals and outpatient settings as well. Communication is another big pile of data that we are generating constantly. So narrative communication, written communication through emails, text messages, and so on. You also have another huge pile of data that includes scientific literature, right? And exponentially growing. So these are kind of some of the examples of the data. Now, I want to start telling you about some of the things, so concrete examples of projects that we have in home care. And so the first project basically is a study that was conducted by my PhD student, Molly Hobensack. And the study is about risk factors that home healthcare nurses and other clinicians associate with hospitalization risk. So in terms of, so this is a publication of this study, basically source, right? And some of the venues that supported this work. Now, we have about 6 million people, as we mentioned, in home care services. About 1 in 5 or 1 in 4 of those individuals are going to be hospitalized during the home care episode. So this is a tangible outcome that can be reduced with appropriate and timely care. Now, we know that people around, in inpatient settings especially, are starting to build clinical decision support tools that would help clinicians identify patients who are deteriorating. So the question for this study was, we really wanted to start exploring what home care clinicians see as factors that are related to deterioration, and understand how those factors are going to be reflected in the electronic health records. So the first question was specifically what risk factors home care clinicians associated with higher hospitalization risk. And then the second question was how to identify and extract this information from the electronic health record. So what we did in this study, we used qualitative interviews to understand the risk factors specifically, to understand where information is captured. And then we also mapped those risk factors to healthcare terminologies. So in terms of sample, we worked with VNS Health, basically clinicians here. So we purposefully approached clinicians of different kinds and with various professional backgrounds. During March and January 2021, we developed an interview. It was a one-time semi-structured interview that we've done, conducted through Zoom. We then conducted qualitative data analysis, so thematic analysis, using code book, and then we mapped risk factor to terminologies. So this is in terms of methods. Now, in terms of participants, we had 15 clinicians that we spoke with, including nurses, physical therapy, occupational therapy, social work, and clinical team managers. Now, about half of those clinicians were nurses, they on average had more than 6 years of experience working in home care. So this was an experienced group of clinicians. Now, in terms of the standardized terminology that we use to map risk factors we identified too, we used Omaha system, which is a great terminology to be used for the outpatient setting specifically. So this terminology is one the recognized American Academy of Nursing recognized terminologies to be used for describing care. Now, in terms of data analysis from left to right, so like that's an example, for example, right? So patient, and the quote would be something like patients who have multiple chronic conditions. So a patient who had a surgery recently and is bedbound, has wounds and diabetes. So we extracted risk factors from that. So the second box would tell you what the risk factors specifically. So risk factors are multiple chronic conditions, bedbound, wounds, diabetes, things like that. And then, we mapped those risk factors to the Omaha system in terms of the signs and symptoms, and also on the larger scale problems. And for some things we didn't find match in this specific terminology. That's expected because for diabetes, for example, it's a disease code. So that has to come from another terminology, something like systematized nomenclature of medical terms known as SNOMED CT. So that's kind of the expectation that disease names would be mapped from another terminology. So that's what we've done. So what we found in general is that a variety of plethora of factors are seen by home care clinicians as factors that are increasing patients' risk for hospitalization, including physiological factors, and you can see some of the categories here, health-related behaviors, psychological and environmental factors. So all of those affect the risk, as one would expect. Now, here is a description of specific risk factors that are associated with hospitalization under the categories of skin, circulation, or neuromusculoskeletal function. So you can see some of the specific things that were mentioned here, and these are physiological factors. If we look further, health-related behaviors, that's the first column, under the umbrella of healthcare supervision, things like inadequate or inconsistent source of healthcare, or failure to seek care for symptoms, things like that would increase somebody's risk for hospitalization. Social contact, limited social contact and income under the psychological umbrella. And then environmental factors would also affect somebody's risk for hospitalization. So in environmental factors, specifically we looked at income, so low or no income on uninsured medical expenses. Now, some of the things, additional things that we couldn't map to this standardized terminology, the Omaha system that were mentioned, were in the areas of patient-clinician interaction. So this is upper left box. So increased communication with providers, increased frequency of care, past hospitalizations. Those things were seen as increasing the risk of patient hospitalization. Some things that are related to clinical profiles, so high number of comorbidities, high number of chronic conditions, older age, medical diagnoses, as I mentioned, and change over time, so change in baseline or lack of symptom improvement. All of those were seen as risk factors, and we were able to map those to other standardized terminologies, such as SNOMED that I mentioned, a couple of other things. So to the question of where clinicians are documenting those risk factors, we found that most of the clinicians that we interviewed here mentioned that they do use unstructured data, specifically clinical notes. And we have two types of clinical notes and home care coordination notes and visit notes that are frequently used to document emergent risk and risk factors. Email communication came up as well. In terms of structured data, only a few clinicians mentioned that they heavily rely on structured data. So like those drop-down menus, drop-down boxes, check boxes are infrequently relied on to document risk factors. And then, agency hotline, so kind of call center where patients would call or their families, and this information will communicate with nurses. So in general, we found that physiological, environmental, health-related behaviors, psychological, and other factors are associated with higher risk. The limitations of this study is that it was, relatively small sample size, one home care agency. We found that Omaha system is pretty good to describe those risk factors. However, additional terminologies are needed when you really want to comprehensively describe using standardized terminologies, those concepts that we're finding. Majority of risk information is contained in unstructured data, so narrative notes are very important. And we, in this study, we produced a comprehensive list of risk factors to add the development of a clinical decision support system. So that was the intent, right? To kind of try to get into clinicians' brains, see what they think are risk factors, and then try to model that using artificial intelligence in the form of clinical decision support. So that was a first study that we've done. So, because we found that a lot of information is included in narrative notes, a lot of risk factors, we did understand that we need to extract those risk factors from clinical notes. And the technology that's making this possible is called natural language processing. So it is a combination of computer science, artificial intelligence, and computational linguistics concerned with interactions between computers and human natural languages. So that's what we're trying to do with NLP. Basically, that's a combination of those fields as applied into the clinical practice. Basically, what we're trying to do is to teach computers how to read clinical texts. So that's kind of the major goal. Now, just a brief preview for all of you to become experts in natural language processing after this presentation. So roughly, natural language processing can be divided into two very broad categories. One category are rule-based approaches. The other category is machine learning or probabilistic-based approaches. So in the rule-based approaches, imagine if you have a project where you need to find patients with major depressive disorder or depression, and you have, let's say, 1 million clinical notes. So it's impossible to review all of those clinical notes by yourself. You know that depression is described in the text using expressions such as MDD. MDD is an abbreviation for major depressive disorder, or depression or clinical depression or something like that. So you would first, for the rule-based approach, you would compile a large vocabulary of those terms. And then you can kind of search for this vocabulary in the text, so kind of keyword search, and you will be able to identify patients with depression right in the clinical notes. Now, in terms of important things that need to be done for this approach, for rule-based approach, when you have this vocabulary, the computer algorithms that you would apply to search for those terms need to be sophisticated enough to understand that when those expressions are negated, for example, and negated, I have an example on the screen. Patient does not have MDD, right? So the computer should be able to rule out depression in this case and say, okay, I see words related to depression here, but actually they're negated by some contextual words. So that's important, so that's at the very least that needs to be done. Now, the process for rule-based systems goes something like that. Computer reads nursing note, right, or another clinician note, finds words and expressions describing presence of depression, makes sure that words and expressions are not negated or denied, right, or this patient doesn't have MDD, would not be counted as a positive example, and repeats steps 1 to 3 for each nursing note, right? So then at scale, you can describe your sample as either having, some risk factors or not. Now, approach number 2 is machine learning. So in machine learning, what we usually do is that we ask, instead of us defining vocabularies and kind of developing those elaborate rules that will help us to identify certain vocabulary in the text, we are asking the machine to do it. So we're applying a series of algorithms that will help us to identify those patterns themselves, rather than relying on us developing those patterns. So for example, right, if we are looking for depression, then we are hoping in those machine learning approaches that when we provide computers with enough examples of clinical notes that describe depression versus clinical notes that do not describe depression, the computer will be able to figure out what are, kind of by itself, what are the rules that define having a depression or not. So, the idea is to provide a bunch of examples. Examples have to be high quality, so human annotated. Usually we have 2 clinicians annotating large data sets of clinical notes for presence of certain symptom, for example, like depression. And then, we're feeding this to the computer, trying to get help and kind of automatically identify things. So, the hope is in this approach, again, is that the computer will be able to identify those text patterns. So, for example, depression or MDD that are associated with higher likelihood of this condition. Now, in terms of methods, you have a variety of methods that are used for something like that. So in terms of machine learning, right, you very broadly have supervised learning, unsupervised learning, and you can see some of the methods. You might be familiar with some of the standard and traditional methods like support vector machines or decision trees, and some newer methods that are being, used more and more, like neural networks, for example, and deep learning that are being used more and more for machine learning based approaches. Now, in terms of the natural language processing, again, computers, the hope is for computers to kind of independently find patients with depression and be able to classify each clinical note and each patient to whether they have depression or not. So that was a very brief preview of natural language processing. Now, in terms of what we've done, right? So what we've discovered is that narrative notes in home care include, from the clinician perspective, include a lot of information about patient's risk. So in this study that I'm briefly reviewing here, we tried to predict patient hospitalization and emergency department visit using clinical notes collected by home care clinicians. Again, right, we have a high number of people that are hospitalized. We know from hospitals that if we use nursing notes, we can predict patient deterioration ahead of time, before it happens. So here in this study, I really wanted to use nursing notes and kind of try to see it. So that was a pilot study, try to see whether nursing notes are going to be predictive of patient's deterioration. And you can see a reference, this was published in Nursing Research, but in terms of methods, we use a large database of home care notes, about 700,000 of notes that were generated for about 110,000 of home care patients. The outcome was a hospitalization or emergency department visit extracted from a standardized assessments that we do at discharge in home. It's called Outcome Assessment Information Set, OASIS. And we applied traditional machine learning algorithms like the naive-Bayes decision tree and random forest to try to predict this outcome based just on the information that nurses are documenting in the notes. So what we found is that here you see in the first column, you see the names of the algorithms, and you see the performance of those algorithms basically across the other columns in terms of predicting this outcome of hospitalization and emergency department visit. So the best performing algorithm is highlighted. That's the last one, the random forest algorithm. It achieved an F score, which is a harmonic mean between precision and recall of about 0.82. Roughly, you can say that this algorithm would be accurate in 80% of the cases. So in 80% of the cases, it will be able to accurately identify people who are going to be hospitalized or go to the ED during their home care. Here are some of the words and expressions that were associated with the higher risk of hospitalization, and those align with the themes that we discovered from talking to home care clinicians. So clinical factors like symptoms, right, came true. That's the first column. Coordination, communication, language related to coordination and communication. So like if MD was called, for example, that represents a higher risk because nurses in home care will call an MD when something is going wrong with the patient. So they'll try to get in touch with MD. Service use, social environmental factors, again, like income came through. So kind of consistent factors that we saw in the clinician interviews were captured by this machine learning. So that was pretty cool. Now, in terms of the discussion for this, so what we found in this work, right, that home care notes are highly informative to identification of patients at risk. So the next kind of reasonable question that we had in mind was about we were trying to imagine a system that will proactively identify patients at risk and alert nurses on concerning trends. And fortunately, we were funded by the Agency for Healthcare Quality and Research to just do this work. So the objective of this study that's called Home Care Concern, building risk models for preventable hospitalizations and emergency department visits in home care, is to use cutting-edge data science approaches to improve timely identification of patients at risk. So that's an ongoing study. Just in terms of where we are in the study, we are close to finishing 2 years of this 4-year study, and we are finalizing the development of predictive models that I will share with you shortly. So this is under aim 1. In aim 2 of this study, we will build a prototype clinical decision support tool in collaboration with home care clinicians and managers to kind of build it into the workflow and build the visualization for that. And then, aim 3 is we are going to talk with home care agencies across the country and try to understand how tools like that, clinical decision support tools like that, can be integrated into workflows at different places, right? Because we are, there is 11,000 agencies, so we kind of want to see how tools like that are going to work in other places. So I said that I will share kind of some of the results so far that we've gotten. So this work was conducted by my postdoc, Jiyeon Song. And here in this project, we are showing that clinical notes add value to risk models for hospitalization and emergency department visit during home health care. So here we compared machine learning models. And you have a citation for this article that was published in the Journal of Biomedical Informatics. So this is the team that I really appreciate and fortunate to work with. Now, the aims of this study were to compare and determine optimal risk predictive performance of 2 risk models and varied data sources for predicting hospitalization, emergency department visit, and home care. And the hypothesis was that, I told you about just using the clinical notes to predict risk. Here, we wanted to combine standardized data, so other data sources, right, that we have, and data is extracted from the clinical notes to improve the performance of risk prediction. So we want to combine data sources, see how the risk identification would improve. Now, in terms of the sample, so it was, we have a sample of about 66,000 patients for about 80,000 episodes. episodes. So patients might have been seen twice in this period of time that we're looking at. And this data is from 2015 and 17. We extracted, a lot of variables, basically multiple things that are documented about those patients from the electronic health records, including structured data and unstructured clinical notes. So we have about 2 million clinical notes that were documented for those patients, including visit notes and care coordination notes. Now, we use a couple of natural language processing approaches that were developed. So this approach was developed by Molly Hobensack, and this is being presented in this weekend at the American Medical Informatics Association annual conference. This paper was nominated for the best student paper, so we're excited about that. Congratulations, Molly. So in this NLP approach, basically, we label clinical notes as either having concerning language or not having concerning language, right? So this is a kind of binary classification task that we're doing here. And the result of this machine learning, basically, we can apply it on each clinical note, and then the machine learning will tell us whether this note is concerning or not. So that's approach number one. In approach number two, we actually build a rule-based system that identifies about 40 specific risk factors in the clinical notes that are based on the Omaha system. Again, this study was published in another article in Nursing Research, led by Ji-Young Song, a postdoc that works with us. And so basically, this approach would identify lots of clinical factors. And you can see some of the examples here of those risk factors that we are extracting from the clinical notes. So, in psychological domain, for example, we are extracting things related to abuse and those signs and symptoms of the actual. So like those specific things that we're extracting are harsh excessive discipline or, bruises, welts, other injuries, things like that. And, so we're extracting a bunch of those factors from the text. So that was NLP approach number two. And here are some of the other things that we're extracting. So physiological domain, health-related behaviors domain, people not taking their medications, for example. So those are a couple of specific things. Now, what we did basically in terms of the machine learning in this study, in step number one, we identified most important features because we had a lot of variables that are associated with this outcome of hospitalization emergency department visit. Then at step number two, we created risk models with different combinations of those risk factors. So risk model number one just used the structured data, and risk model number two, we added data extracted from clinical notes. And we applied those algorithms you can see on the screen to kind of create those prediction models. We then evaluated the performance of the models and tried to identify the best performing model. Now, this sample had about 10,000 people, or about 8,000 people who were hospitalized or visited ED, and in the paper would provide demographics about the sample. In terms of the clinical notes, we had an average of 28 clinical notes per home care episode, and people with higher risk for hospitalization would have a larger number of clinical notes. Then on average, people had about 3 problems using the Omaha system. So, 3 risk factors documented per home care episode. More risk factors for documented patients for hospitalization and ED visits. So these are some of the examples you can see more about in the article of, what risk factors specifically we found using this approach. And this is kind of the final result for this. So the random forest model outperformed other models in terms of risk prediction. It achieved something like 81 to 86%. So 81% of risk prediction. It was comparable to the SVM, support vector machines models. And we saw improvement over the board when we added information extracted from the clinical notes. So there was a constant improvement of about, the highest improvement we saw was about, 17, 18% in terms of risk prediction. So we do see the value of clinical text added to other structured data in terms of risk prediction. That's what it shows. So risk prediction improves basically when we add text mining and natural language processing to the mix. Clinical notes combined with structural assessment are good predictors of patient's risk. The future direction I described briefly, right? We will be implementing those models into clinical workflows and developing visualization for clinicians and kind of helpful clinical decision support tool user interfaces to help clinicians identify patients at risk and intervene in time before deterioration happens. That's the publication. So this was another example that I wanted to share. Now, in terms of, we developed an open access natural language processing system that's called Nimble Miner. So this system is available for anybody to download. It's on GitHub, and some of the examples of things that we've done with this system, it's relatively easy to use for natural language processing projects that I described. So, some of the examples that we've done, other things, we identified fall-related information, so who fell, who didn't fall. We identified dementia symptoms in the clinical notes. We identified symptoms associated with high risk emergency department visits and hospitalizations again, and risk factors for urinary tract infection and multiple other symptoms. So you're welcome to contact us if you want to use it or just download the system. So that was key technology number one I wanted to talk about, natural language processing. Now I want to tell you a bit about an exciting and new area where there is a lot of signal. It is speech recognition. So a verbal signal, right? That's a different type of signal that we get. We have a lot of interactions with patients, basically, as clinicians, right? So in the series of studies that I'm going to present, we're going to look into what specific things we can extract from those conversations. So here is an example of a first study, again, conducted by Ji-Young Song, that was published in JAMA Open. This study, basically, what we did here is that we recorded and transcribed 22 patient-nurse conversations in the home care. And then we compared the information that was described in those conversations and things that were documented in the electronic health records. So we're trying to see what will be kind of the effect of having access to the speech data and what additional things we would find in the speech. So basically, that's an example of one of the annotations that we did. So we annotated conversations between patients and nurses in home care. So, for example, you can see that in the highlighted portions, highlighted in red portions of this conversation, say, for example, I didn't take anything. So, patients didn't take this medication they were supposed to take. And then we mapped this to the Omaha system problem of medication regime, does not follow recommended dosage or schedule. The other mentions nursing interventions, actually. So nurses said, take it because the leg will swell up more. So this is an intervention that's focused on the problem of edema. And the intervention is teaching, guidance, and counseling. So basically kind of describing medication side effects or action items. Now, we then took those transcribed conversations, right, and problems we extracted, and we looked whether those problems were described in the electronic health record. So we looked at the narrative notes, like whether those problems were described in the notes, maybe. So here, the verbal communication would mention problems with gait and kind of walking. Narrative note would say patient ambulates with walker, not steady on both feet yet. So, it's described in the notes appropriately. And then, there is also some description of those problems in the structured data. That's the last column. Now, in this example, we have something that was not documented in narrative notes, So there were some problems mentioned that did not appear in the narrative notes and did not appear in the structured data. So this problem was just mentioned in the speech. Overall, we found that about 50% of the problems that were mentioned in the speech were not documented in the electronic health record in either narrative or structured form. We found that about 20% of interventions were not documented in electronic health record. So that speaks to kind of the quality. And then, in total, about 30% of both interventions and problems were not documented in the electronic health record. So, in terms of results, again, highlighting those facts that 50% of patient problems, 30% of nursing interventions are not documented in electronic health record. They're expressed only verbally. So that kind of shows you the value of this verbal communication. In terms of, we also found a concerning trend here that under documentation of problems among Black patients is twice higher. So we found that among Black patients, about 60% of the problems are not being documented versus white patients for whom only 35% of the problems are not being documented. That's very preliminary, but it definitely requires further investigation because we had a very small sample here, so we can't extrapolate and say anything in general, but that kind of requires further investigation. So this project just, it starts to answer this question of like, what's important, what's being discussed during the verbal communication. Now, the second question that we were asking is, what's the best way to record those patient-nurse communications in the home? So we conducted the study that was led by my other postdoc, Miriam Zolnouri. This study developed a pipeline for recording, basically, patient-nurse communications. And this was published as well in the JMIR Human Factors. So you can review kind of the results of that. But, in this study, we developed this pipeline of recordings. And then the other question about this work, right, is about accurate transcription. So basically, I told you about our experience working with free text data, so narrative clinical notes, for example. Here, to be able to interact with this data that's been generated as a result of patient-nurse conversations, we need to transcribe it from speech to text. So we did apply automated approaches to do that, and the automated approaches basically have an error rate of about 25%. Which is, to some extent, it's concerning, but that can be improved, basically. So we're working on improving this error rate. And, maybe for some scenarios, actually, that's an acceptable error rate, depending on what we want to do with this data. Now, we then did a pilot study where we recorded conversations for about 40 patients in the home care with their nurses. We then identified in those conversations, we adapted our natural language processing system to identify risk factors and identified risk factors in those conversations. And the risk factors were the following things. So circulation, medication regime, neuromusculoskeletal function problems, pain, respiration. So all of those things, we were able to find them in the conversation, transcribed conversation with a pretty good accuracy. So the F-score is about, the best F-score for the entire conversation was about 0.9, so 90% accuracy roughly. Now, here's a couple of other examples of things that you can identify in the conversation and, things that you can actually mark up with natural language processing. So you can start understanding lexical richness. You can identify specific risk factors. You can identify other elements of what's being said, for example, some emotional descriptions, right? Description of emotion and things like that. So these are important pieces that are going to be in the conversation. Now, the final thing we did with this is that we actually used about 40 of those recorded conversations to try to improve risk prediction, right? So I told you about the previous project where we are just using narrative data and structured data to predict risk. Here we added recorded conversations as well. And we saw an improvement of about 10% risk prediction performance when we added those verbal communications to the mix of machine learning, so combined unstructured data, narrative notes, and structured data plus the recordings. So we did see an improvement. We submitted a grant that's been reviewed very positively, and we're waiting to hear that we might be funded for a large grant to kind of continue this line of work and collect more comprehensive, larger sample. So I described the next steps to you. And the last example of speech recognition I wanted to mention, again, this work is conducted by Miriam Zalnouri, who was recently funded with the K Award, so K99 Award, to continue doing this work. So in this work, we're developing AD Screen, so a novel machine learning-based tool for automated screening of patients at risk for Alzheimer's disease and related dementias. And in terms of basically the idea for this study, right, is to use speech as an indicator of cognitive impairment, specifically dementia. Now, there are a lot of clues in the language and the way how people speak and what they say that we can kind of glean and learn about, and then use it for identifying somebody's cognitive status. In terms of specific aims for this study, basically what we wanted to do is we wanted to model patients' ability for phonetic motor planning, semantic and pragmatic levels of language organization, and vocal and semantic expression and of emotion. So, we're looking for emotions as well in the speech. And then in aim 2, we developed and evaluated machine learning algorithms for proactive identification of patients with Alzheimer's and related dementias. So here are the components of this pipeline, this analytical pipeline that Miriam created. These are the components of phonetic motor planning. So basically, voice turns into a waveform, into a kind of a wave description. Then, we have also extracted emotions. Emotions can be extracted from those acoustic features or from the linguistic features, basically based on what is being said. And we used a system that's called linguistic inquiry and word count to describe those emotions. And then, we also modeled the syntactic and semantic levels of language organization. Basically, this idea is to measure the language richness, for example, right? Semantic richness of the language. And in patients with dementia, we sometimes see that this, there's not much of a richness that people have. So that's kind of associated with dementia. In terms of the data set for this study, we used a recorded data set, a pretty old data set so this data set would have 80 participants with Alzheimer's and 80 cognitively intact participants. And the recording was of this picture, basically. So participants are asked to describe what's going on in this picture. And that's called the cookie theft neurological test, basically. And then based on the results, right, based on what people are describing and how they're describing what's going on in the picture, you can make, pretty good guess of whether they have some type of cognitive impairment. This is a pipeline that we used for that. So, pretty elaborate machine learning pipeline that took all of those features from the recorded conversations, transcribed them into text, and then applied machine learning. And so what we found basically are the feature, this is the predictive ability of the system. So in general, and this graph represents the AUC curve, basically. So in general, we achieved a pretty good prediction ability when we combined acoustic features, linguistic features, and emotional features. So this is the red line that's kind of on the top of this graph. The second best prediction was achieved with acoustic features and linguistic features, and then the least powerful prediction was achieved with just acoustic features. So that's what we expected going into this. When you add more features, you have better prediction. So this is just description of other metrics that we use to describe that. And here, the next steps is that, we can screen Alzheimer's by recording patient's voice. Now, we know that larger studies with more recent data are needed to create those algorithms, and algorithm performance need to be evaluated in different racial and ethnic groups. We know that language and the way people speak varies between different people, right? So imagine African-American vernacular, for example. Models need to be created for that. All right. So that was a lot of information. We talked about natural language processing and speech recognition with specific examples. The take-home message, again, is artificial intelligence can help to automatically extract important insights from nursing data to improve patient outcomes. And I hope that I had examples that are helpful in highlighting some of the things we can do. And in God we trust, all others must bring home health data. All right, now we have some time for questions.
Thank you so much, Dr. Topaz, for this great presentation and also for the really rich and comprehensive work you're doing. Just to remind our audience that you can post your questions in the Q&A box. We already have some, so maybe we can get started with the first question. How do you foresee scaling and operationalizing your findings? Are patients amenable to having their speech passively recorded?
All right, excellent question, right? We are thinking a lot about that. So in a study that I briefly mentioned that created this pipeline for recordings, we actually conducted qualitative interviews with patients and nurses about being recorded, right? What their attitudes are. What we found actually is that patients were in general very positive about recordings. So they liked the fact, they thought that they can use those recordings to remind themselves what was described during conversations between them and nurses. So that kind of was a positive thing, right? So they didn't have a lot of concerns. On the other hand, nurses had more concerns because they actually, they really wanted to know that this recorded conversation is not going to go to my manager, that's going to look at this and evaluate the quality of this, or be used for other things. So we got some concerning stuff from nurses, right, and less concerning things from patients. So that's kind of the state of this right now.
There is a question about your approach. Do you record the nurse-patient conversation for your analysis? And can you talk a little bit about the issues of patient consent and family consent?
Right. So these are great questions, right? We did develop a pretty elaborate pipeline where we would, approach a patient first, basically ask them for their consent, and then before we start any activities of those recordings, right? And then, so, we did have those elements integrated, right, into the kind of the study workflow. And then in terms of the actual recording, right, an ideal recording would be where you have a microphone that's kind of next to your mouth. The closer it is, the better it is. So this is a challenge, right, in home care where people are moving, it's not a static situation where, you sit, for example, right, in your primary care physician office sometimes, right? There's a table in between you and the physician. You can put a microphone there. It will capture, both of your voices, something like that. In home care, we have to attach those microphones to the patient and to the nurse. So, that's problematic, basically. So we're thinking a lot about what can be done to make the situation easier and less burdensome for the home care nurses, right, to record as well as for the patients. So, we're thinking a lot about that. No good answers at this point.
Do you look for language that is missing as a prediction of risk? More specifically, no mention of cognitive or functional status?
That's a great question. So we usually look at the things that are present in the conversation, right? Kind of when we explicitly look for those risk factors. In some way, right, when we use machine learning and convert those conversations into large vectors of words, right, this would account to some of the missing, things that were not said, right, basically, and identify those as patterns maybe for deterioration. But that's a great question, actually.
A follow-up question is, which factors do you see as the most influential in transcription error rates?
Yeah, thanks. Tough questions. So there is a bunch. Imagine, right, those transcriptions are being done in patients' homes. And what so lots of background noise. For example, a TV that's working, right, full volume, and like, you have a transcription of a patient and a nurse and the TV and some other family members, dogs bark, cars honk, whatever, fire alarm goes off. Things like that, they always happen, right? So that's one type of background type factors. Then there are factors that are related to the patients themselves. So heavy accents, right? Things like that are also affecting speech transcription. And so, there is I think, we have it's surprising how much those methods improved in the last 3-4 years. I wouldn't imagine, achieving this quality by just using models, speech recognition, transcription models, right, that are out of the box. And they can be fine-tuned, made better, basically, right, for the specific domain. So, there's work that has to be done in kind of improving those transcriptions, right? But, even what we get right now, right, is good to some extent, right? I don't know, if it's going to meet the criteria for high quality clinical work, right? What's being documented using the speech to text transcriptions, but to some extent, right, it does work for our risk prediction, for example. So it's kind of use case.
Okay. Our next question is actually from Dr. Kashian, who is congratulating you on your amazing work.
Thank you.
And it's pointing out that speech patterns are known to change in delirium. Could this help distinguish dementia from delirium, or delirium superimposed on dementia?
So great question. I've heard about some people that are starting to do that now. Yes. So the answer is, we think that it's possible, right? And you have speech patterns, so cohesion or something like that, patterns related to that in the speech that can be used to identify, people with delirium. And I've heard about a project that does that in lucidity as well, right? So like identify periods of lucidity. I know there was an NIH call, a couple of years ago, right? So I've seen work done on that as well. Kind of that's going on right now. So that's a great question. It's an active research question.
Great. Let's take one more question. Our participant congratulates you and your team for your work on persons with ADRD. Are there any longitudinal studies for these cognitively impaired patients that can compare your studies with their current diagnosis and cognitive decline? And do you have ability to apply such studies in other languages?
Complex question, right? So longitudinal studies, we just finished an R21, so fairly large study where we tried to use natural language processing to predict the diagnosis of dementia or an other of ADRD, basically, right? Alzheimer and other dementias in the home care population using a combination of, again, structured data and clinical notes. It was successful to some extent. It was very good, actually, the prediction we got out of this. So that was the outcome. We measured it up to 4 years after a patient was discharged from home care, right? So, in a sense, it's somewhat a longitudinal follow-up after the outcome, basically, right, when people were diagnosed. So, and there are other studies like that that I've heard about, right, that are developing longitudinal data sets, but more work needs to be done to kind of longitudinally really follow up after patients, right? Because home care is just this one episode, right? We're not combining it with data from primary care, for example, hospitals, right? That'd be ideal, but there are barriers to that. And then other languages, I have not heard about this being done in other languages, but there's a potential definitely for doing this work in other languages.
Great. I know there's a couple more questions in the Q&A box, but since we're running out of time, I would suggest you contact Dr. Topaz directly for more discussions on his important work. I want to thank again Dr. Topaz for being with us today and all of you for attending, and hope to see you all for our December 1st webinar, which will be Dr. Berich. Thank you again.
Thank you. Bye-bye.